Welcome to our breakout session 2 and session 2 on Beyond COVID-19 today. My name is Kirsten Grosefried. I'm an advisor at the University and Hospital Partnerships Program at BIZ, the German Development Agency. In this session, we will discuss about what partnerships have learned during the 12 months and how this will influence their work in the coming year. We will also discuss if there was a shift in power and how this will influence the partnerships. And we would like to know if the partnerships have new projects or partners to provide essential health services. In our sessions, we have some polls, and I would like to have a first question on the poll now to get an idea who is in our audience today. The question is, are you currently involved in an institutional partnership? Okay, thank you. You can see the result now. We have half of our participants from a northern part in an institutional partnership, and 30% are not involved in an institutional partnership at all, while 15% are from the Global South partner. I would like to give a short overview of the structure in our session today. We will have 3 presentations. One presentation from a partnership between Madagascar and Germany, one between Zambia and the UK, and one between Madagascar and Switzerland. I would like to ask all presenters at the beginning of each presentation to present yourself and your partnership shortly. After each presentation, we can just have urgent questions, and then we will have a discussion after the 3 presentations at the end. And now we can have the second question for the poll. This is on how the focus of your partnership has changed to include more work on pandemic preparedness. Okay, that's interesting. We can see that half of all partnerships have changed their focus, and this is not applicable for almost 40% of you, and only 10 have not changed their focus. Now I would like to ask Gracia to present herself and the partnership, and you're welcome to start your presentation.
Hi, everyone. First of all, do you see and do you hear me well? Somewhat well. All right, because the problem is upstairs, they're doing some remodeling, so I hope you can still hear me quite okay. And then I will share my screen.
Yeah, you.
Okay, I believe you see something now. All right, so welcome everyone. I'm Grazia Andrea Miadana. I'm a master's student in the Bioinformatics Master of the Freie Universität or Free University of Berlin. I have been working at the Global Digital Health Lab from the Charité since last summer. And today I want to talk about our ongoing study about the impact of COVID-19 related policy measures on maternal health care in Madagascar. So first, a little bit about the partnerships. So our lab itself works closely with the German NGO Doctors for Madagascar and the platform M2Madi. And there has been a long history of successful partnerships in Madagascar with public as well as private hospital partners, with the target of improving health outcomes through various interventions. And at our lab, we aim to measure the impact of these interventions with projects ranging from tuberculosis projects in the southern part of Madagascar to maternal health projects. And today I actually want to talk about the maternal health partnership that DFM, or Doctors for Madagascar, has with the Ministry of Health in Madagascar. So as I mentioned, the partnership between DFM and the Ministry of Madagascar, Ministry of Health in Madagascar, focuses in this case on maternal health. And the maternal health project is actually a mobile maternal health wallet. And with this wallet, pregnant women in the capital of Madagascar, in Antananarivo, are able to save money using a SIM card or a mobile phone, which is matched at 50% and pay exclusively for facility-based deliveries. But they can also receive digital vouchers for free ANC drugs and prenatal ultrasounds. And as I just said, the platform that we use for this mobile health wallet is called Antomadi, which is a multi-payer platform that connects the beneficiaries and the health financing. So the patients can use a mobile phone or a SIM card to save, send, or spend money, or also get health information, whereas the healthcare providers use a tablet to identify beneficiaries, submit claims, and receive payments, as well as securely transmit medical data. And the insurance providers or healthcare payers use a desktop interface to manage claims and beneficiaries, monitor real-time data and fraud protection, as well as distribute behavioral nudges. So now the question is, why did we conduct the study about the impact of COVID-19 related measures? And it actually started with us, the data science team, so to speak, noticing changes in the data extracted from our dashboard. So we realized, for example, that there were less deliveries whenever there was one of those measures implemented, for example, a lockdown. And to confirm this suspicion that COVID-19 or the COVID-19 measures has impacts on our partnerships, we wanted to conduct the actual study. But first, I want to run you a little bit through all of the measures that were relevant during the time of the data that we extracted for the study. So from on the 10th of February 2020, there was one of the first suspensions of flights to and from China by the Malagasy government. And about 6 weeks later, there was the first detection of COVID-19 cases, actually from flights coming in from Europe. So that led to the suspension of all international flights to the island and a declaration of public health emergency state. And about another few weeks later, there was a very strict lockdown, so from 5th of April to 18th of April. But 1 month after this lockdown was lifted, there was the first COVID-related death. And also in general, numbers started rising again, which is why from July 4th to August 22nd, there was another strict, and as you can see, longer lockdown. But then in September, beginning of September, the national transportation was progressively reopened again. And as of March 18th, there was a record of a total of about 22,000 COVID-19 cases with 338 deaths until that date. So now we come to the study. And as I said, the objective was to analyze the effects of these just mentioned measures on maternal health services in Antananarivo. And the study consisted of 7,631 patients from a total of 29 basic health facilities. It was conducted, or the data was extracted from the 1st of January 2020 to the 5th of October 2020. However, I just mentioned a lot of different interventions and events, but we just focused on the 2 lockdowns. So the 2-week strict lockdown in April, and then the longer also strict lockdown in July and August, with the outcome variables being checking the vouchers for the ANC drugs, the number of deliveries, of general claims filed, number and amount of total savings, as well as the amount of savings per deposit. And to do this data analysis, we used an interrupted time series analysis and a segmented linear regression. And even though those are still preliminary results, just generally what we noticed was that there was an impact on all partnership activities, which of course potentially could lead to long-term consequences. So if we take a closer look, then we could see that the use of the voucher program was actually not significantly reduced in the lockdown, or yes, in the lockdown compared to when the lockdown was lifted or before. And the facility-based delivery, so which is equal to the use of the health wallet, was in fact reduced by about 45%. And now we also wanted to understand, so even though that there were these changes, we wanted to understand what could potentially be the reason for those. So we looked at the number of saving transactions, and those were interestingly significantly lower, but also the average amount per deposit was significantly decreased by 41.8%. So not only did the beneficiaries save less times, but also each time that they saved, they significantly saved less. So generally what we realized was that the COVID lockdown indeed had severe effects on the savings and health-seeking behavior of the pregnant women. But as I said, the voucher program was less affected. So that could be interpreted as financial barriers being the main reason for why less patients sought into institutional care, rather than the actual fear of catching or being affected with the disease. And because the economic impact of COVID will most likely still increase in the next month, if not years, there have to be even more, or there should be even more efforts for financial risk protection and universal healthcare coverage. Thirdly, our study also showed that digital tools can deliver real-time data to react in times of crises, because they can, first of all, monitor for example, savings and health-seeking behavior of the individuals, but can also improve the partnerships because they can play an important role in strengthening the health systems. So that was already all I wanted to talk about today. I guess questions we will do later, if I'm not wrong, isn't it?
Thank you very much for your interesting presentation and for keeping the time. Is there any urgent question on this presentation now? The discussion we will have later. I cannot see that there's a question. Then we will proceed with the next presentation from Tris and Priska and Joy. Please introduce yourself and your partnership, and we are looking forward to your presentation.
Thank you very much, and good afternoon, and thank you for inviting us to present this afternoon about our research partnership with the UK and Zambia. So my name is Chris Carter, and I'm Senior Lecturer at Birmingham City University, and with me today is
Priska Nkonka. I am the head for the Lusaka College of Nursing and Midwifery here in Zambia, Lusaka.
And I'm Professor Joy from Birmingham City University.
So to start with, what we're going to do is we're just going to provide some context on how our health partnership works. So our health partnership commenced in 2015, and our focus has been on strengthening the patient pathway and recognising that care should always escalate. So we initially started work around critical care nursing, and then we moved into emergency and trauma nursing, and used national workforce reviews in order to guide the work that we've done. And as we recognise that the care pathway should always be increasing for patients, so if a patient is involved in a road traffic accident, they should then receive paramedic care, care in an emergency department, safe surgery and anaesthesia, and then critical care. So care is always escalating. However, from our perspective, from a project perspective, we worked from the highly technical critical care aspect and have been moving almost in the other direction, and now scaling up emergency and trauma nursing with a view to moving into the community. So when the COVID-19 pandemic hit, we needed to change our project activities to meet the identified need. However, a lot of the work that we've been doing around critical care and emergency trauma and national workforce planning were actually on track, and actually were supporting the Ministry of Health's strategic direction. And one of the big lessons that we've learned is the need to strengthen nursing and specialist nursing practice. And this has been really the direction of travel we were going before the pandemic, but also as we move into the second year. So I'm going to hand over to my colleague Priska, who will take you through the next part of the presentation.
Yeah, so the lessons learned for the new norm, I think we saw that with the COVID-19 pandemic, there was a lot of demands on all areas. In the clinical area, we found that there are a lot of demands, of course, for the nurses, for the critical care nurses, and all the nurses in different areas. And being at the college, we saw that even our students, especially those who are in their final year, and those who had come for a one-year program, who are already nurses, but they wanted to specialize again, they were also deployed with that to the clinical areas. And then even the staff, because the country had to open different areas or clinical settings for the COVID patients. So we found that nurses were being moved around from different settings to these areas where there were centers for COVID. And even in the school, of course, we had to see that even the students also had to be part of that. And even then, the teaching was affected, and even as a college, we had to re-strategize on how we're going to continue teaching among the COVID pandemic. So initially, we had, through the authorities, of course, we saw that all the students were oriented or trained by the provincial health office to that, so that they have knowledge about COVID. And then, because at that time we had to close school, and so we needed to continue teaching. So the online teaching came into being, and then we had to look at the theory and then also the clinical competencies. We understood that you can give theory or online, but as nursing is a hands-on. The students and also the teachers, they had to practice. So there are all these areas where we had to say, okay, yes, we are offering the lessons online, but what about the practice? But also even the theory, to us, it was kind of difficulty because of the limited internet. As it is, Zambia is still a resource limited area, and the internet is not yet up to 100%. So we had challenges with internet, and also some of the students, a few of them did not have smartphones, and because of that, sometimes we had to send lessons by WhatsApp and so on. And so access to computers was also a challenge. And also we saw that even the volunteers, people that were helping out in areas and also even in teaching, that also had reduced because of the fear of the COVID. Nobody would really like to come through, or even in the clinical area, even to teach the students in the clinical area. And also we saw the high demand of skilled staff, especially the critical care nurses. Because in Zambia, it's only ourselves at Lusaka College of Nursing and another college in the Copper Belt who are providing critical care nursing at the moment. And the nurses who are trained in critical care, they are few to cater for the whole country. And so we saw great demand, and this is the time that the country really appreciated the skills of a critical care nurse, because they were needed actually to man the ICU and so on. And also the impact of the COVID-19, and we saw that it brought a lot of issues to us, both at the college and also in the clinical area, because students first, they were they had gone on leave. We had asked to to let students go out, but then we had the challenges because the students needed to move forward. Yeah, and we also do new enrollments. So these were delayed. There were a lot of delayments in enrollments and also in the examinations, and also just the staff were not, were afraid, everybody were afraid about contracting the COVID and so on. There was a lot of fear among the staff, both in teaching and also in the clinical area. But moving forward, short and long term, and so we saw that building on the national e-survey of the nurses that we did. So after doing this, then we had to train our students. So we trained about 973 students, and they completed the blended learning, because at the school, at this college, we mainly use face-to-face. So during this COVID now, we had to say, so how else can we offer this? So with our partners, we had to do a training to scale up and the blended learning, where students would learn online, but also give them an opportunity to practice. So we had that number trend in that. And also the revised emergency and trauma curriculum, and this was revised. And we are so happy, and this was done in collaboration with the General Nursing Council of Zambia, but of course being spearheaded by the partnership, that's the BCU and the Lusaka College of Nursing partnership. And we are also happy to say that we also revised the Bachelor of Science in Critical Care Nursing. And this will be one of its kind, because at the moment we don't have the training we are offering is just at advanced level diploma. But now we are going to start offering critical care at bachelors, and we are going to be the pioneers with this. So we are very happy that this collaboration has actually brought this, and it's actually the talk of the country and a lot of people, because it's also created a career ladder for our students. So everybody is happy, the Ministry of Health is happy, the General Nursing Council is happy, and us, even the partnership, I think we see that we have contributed greatly to the nursing education in the country. And also through the survey, we're going to add on to the lectures that we had formed, I mean, to just enrich them, because with this partnership, we don't want to just concentrate in town or in the urban areas, but we want to scale up into the rural areas. So we are developing CPD materials, and these we're going to take them out to rural areas, some identified rural settings, to also teach the nurses actually, and the students we are going to find there. So I just wanted to, the picture on the side this picture was taken during the time when we were actually developing the materials. During this time, we developed even student-specific COVID-19 materials, and we are happy that we partnered with the Ministry of Health and the Zambia National Public of Health Institute. So we have some members there who are very cardinal to this workshop. And then moving forward, we see a scale up of Zambian nurse education and training. And as we said, that the bachelors in critical care nursing, I mean, this is going to start this July, getting the July intake, and we are working in collaboration with the Levi Mwanawasa Medical University. We're already talking, and the curriculum has been accepted, and starting in July, this July. And also the emergency and the trauma nursing, again, this we have revised the diploma curriculum, and we are going to implement this at bachelor's level again in January 2022. And then we are so happy because of the partnership, because at the moment in Zambia, we don't have people trained at master's level to offer critical care nursing or emergency nursing at bachelor's level. But with this partnership with the BCU, we have seen that we have actually commenced a training on, that is the bachelor's critical care and master's critical care, with of course a pathway in emergency and trauma nursing. So it started this February this year, and at the end of 2 years, we are going to see people, or our lecturers actually, are trained at master's level and also trained at bachelor's level. So this is creation of faculty, and we are going to see that we're going to have teachers in classroom teaching, and also some also to offer the clinical, I mean, teaching in the clinical setting. So this is one of its kind in Zambia. So this is BCU in Zambia. So even here where we are in the office, we call it the BCU in Zambia. The partnership is growing. And so through the same partnership, we are going to, our colleagues, the BCU, they are trying to organize some people from the UK to come as volunteers, to come and offer some teaching in critical care nursing, and also in emergency and trauma nursing. And also as a college, we are going to start this July again, starting another program, neonatal intensive care nursing. And we are also happy that our partnership, actually, they are going to also find some volunteers to come and help out as we start the neonatal nursing this July. And on the picture there is that's the Lusaka College of Nursing, and that picture is it was a launch of the Bachelor's Master's program, and we have the director of UTH, that's the Invest Teaching Hospital, where the college is anchored, and his deputy and the students there. Those students are actually lecturers already, and they are coming from different settings, both from colleges and also from clinical settings. That's the end. Yeah,
Thank you very much. So that completes our presentation. So if we can take questions, or we can wait till the end. Thank you very much.
Thank you very much for this optimistic presentation. Are there any urgent questions now? There's one question in the chat, but this we will have then in the discussion later. And then I would like to ask Caroline to present herself on the partnership and start with the presentation. Thank you.
Hi everyone, can you hear me?
Yeah, we can hear you.
Okay. Hi, so my name is Caroline Wenske. I'm an OBGYN by training, and I am actually in Geneva. I work at the University Hospital of Geneva, and we collaborate with Madagascar as well, but the north part of Madagascar. Since 2015, I will give you a rapid background in a few minutes. And I'm also part of the Takemi program at Harvard School of Public Health, and I've just been 1 year there when the COVID-19 pandemic started. And so I will start with presenting you the project very briefly, and a little bit kind of thoughts that we have during this last year about this project and how we readapted the objectives and the way we were working with the partners because of COVID-19. So the title of the project is an integrated obstetric simulation training to improve respectful maternity and newborn care in Madagascar. So initially the partners were the Centre Hospitalier d'Ambanja in the northwest of Madagascar. We will explain you why in a while, the Geneva University Hospital, and the NGO Enfants du Monde, which is an NGO based in Geneva, expert in training around respectful maternal care, but not really around clinical care. So we thought it was a nice way to start the collaboration, and we were very happy to propose this project to the ESTER program. How can I move forward? I can't. Okay. So everything started in 2015, where I moved in Madagascar for a little bit more than 1 year to implement 2 projects. The first one is the one you see on your left, about cervical cancer screening and treatment in a partnership between the University Hospital of Geneva and the Centre Hospitalier d'Ambanja, using the mobile health technique, especially not only for medical electronic records, but also for diagnosis and treatment around like VIA or VD methods to detect precancerous lesions. And then with another project around maternal care, antenatal care specifically, which is called PANDA, Pregnancy and Newborn Diagnostic Assessment, which is an integrated program using mobile health to help providers to deliver standardized antenatal care using this icon-based system, which is directly uploaded on a medical unit, which is like accessible, obviously with security and privacy protections, but from all over the world, from experts that can have access to the medical records and then give feedbacks if necessary. But it contains also a system of alerts, so you can be whatever in a rural area, and you will have some alerts if something gets wrong with the antenatal care visits. And so along all those years, even after I came back, we continue working on those 2 projects in this little district on the northwest. And I think it was very useful, not only for the project, but the relation that we started to create with the health providers and the health system in that specific district, that allows us to create a trust relation. And when COVID-19 pandemic exploded all over the world last March, February, health providers started to ask us help about how they should behave with maternal health and with like emergencies during this pandemic due to the restrictions and to their specific situation. It was not very clear because, as we all know, and my colleague at the beginning, the first presentation says, it's also difficult like to implement restriction when cases were very low and indirect like impacts can be very heavy. And so we delivered in very quick way, in 1 week, some videos and some health communication material for vulnerable populations to this specific region. And then the Ministry of Health asked us to deliver it all over the country, and the Global Dying Council asked us to share this material for this specific context in rural areas in low-income countries. And sorry, I have some problems to move on with my slides. Okay. So I really want to thank you, the team we are working with in Madagascar, because we included a new partner after we started the Esther project, which is the Ministry of Health. It started because of COVID-19 initially, because before it was only a north-south interaction with the Ambanza district hospital. But we thought it was useful to include a national level of few persons, strategic person in the capital, to be able to coordinate the new way we were starting to develop the project. And so this is the coordination team from Geneva University Hospital. It's me, then we have a midwife and Dr. Siri at the Ministry of Health. And then we have Dr. Paulin and Dr. Vwangi still at the center of Hospital Center of Ambanza. And so how we restructure it. At the beginning, it was a classical like training that was asked from our colleagues in Madagascar, asking for emergency trainings. And during COVID-19, they asked also, we would like to have more training on like protection, health, personal protection, health behaviors, etc. So we decided to divide it in two different phases. The first one was around respectful maternal care, which was really something they wanted to learn more about. So we started from a module on COVID-19. It was only an e-learning based in collaboration with Enfants du Monde NGO about the situation on maternal health due to the COVID-19, the rights for maternal health, mother and babies, and what does it mean to establish a respectful communication among patients and among providers. And so it's around that we developed the first module. And the second one will be based on e-simulation, which is also a new concept that we were not used to work with, around emergency obstetric and newborn care, and doing a baseline. And then we reinforced the local trainers team, which was not initially our plan. And then we will switch all over during the specific training session in June with the e-simulation method for the personnel. And I will just explain a little bit more about how it changes from our initial thoughts on simulation that transform in e-simulation. So a few questions I will answer to just explain how it changes. What have we learned over the past 12 months, and how will this influence our partnership for the future? So I think the main thing is that we change the way we are working with our partners in terms of task shifting, in terms of it's really different to go there or to be there and then to transmit the training, rather than really reinforce the partnerships and transfer it to the local partners. Change the rules of each partner, because it was not initially, it was the University of Geneva who was like responsible for all training, and now it's absolutely not the case. We adapted, of course, the topics that we will deliver during the trainings, not only for COVID, but also for respectful care, for communication among teams and leaderships, and for all the topic around health worker protections. We included a few new partners, and we reduced the number of trainees because we wanted to be sure that the few themes that they asked for will be covered, and we increase the number of trainers, and we reduce it to 6 teams. We prefer to do smaller to start, but very intense for the trainers and the trainees. The next question will be, in which way we can see a shift in power? I partially already answered, but I think based on the relation of trust that we constructed in the last 5 or 6 years, I think we could rapidly answer in this kind of preparedness to the COVID-19 pandemic, which is not the case in some other countries that we were collaborating with, because there is really this continuum of working together, and especially in a direct way, health worker to health worker here and there. And I think we trust in them and they trust in us. And I think it's a really important characteristic to be a successful collaboration. The use of technologies, as the colleague says before, I really believe that the new concepts of e-learning, but in which way it's not only a platform, but it's to develop storylines, new ideas, new way to interact, to e-communicate, because as we don't have meetings, for example, use WhatsApp, Messenger, whatever can help to put people in a security, safety and safe environment to learn and to interact between each other, and not in a judgment way. And so for the new project, we would like to continue that, because at the end, this training program for us, it's more a pilot study right now, because it's more based on, okay, let's put the basis to structure a team in 4 different, between 4 different partners, and then try this e-simulation and e-learning at a small level and see if we can expand it at a national level, and develop new models depending on what will happen at the baseline level, maybe stock management, maybe improve more the resuscitation with the newborns. That's why our neonatal unit will be included. And so we are very excited about this long run program in a very practical way to be collaborated. So for us, I think the main take-home message from this COVID-19 pandemic would be to use technologies much more intensively in some ways that maybe we wouldn't expect to be efficient, and we called it technology assisted partnership, so TAP. This is completely invented, but I think it's a nice way to associate technologies but with partnership, which is not only data but also collaboration among teams, and create new opportunities and way to establish trust, because at the beginning we were a little bit sad we will not be able to be there. It's different to do to be there and to create the team and to create the training, but there's some other ways to establish this trust, and I think we need to be a bit creative to search for that in order to have an impact on mother and baby's health. Thank you very much.
Thank you also very much for this interesting presentation. And I thank you to all the 3 of you for keeping the time. We are very good in the time now, so we have a lot of time for the discussion. And before we will start the discussion, I would like to ask the last question for our poll. The 3rd question. So will the pandemic change the way you work together with your partners in the coming 12 months? Okay, thank you for answering. So from those who have an institutional partnership, more than 40% said yes, it will change substantially. So with less travel and more distance learning and meetings. Okay, thank you. And now I would like to open the discussion. We already have one question, but this is already answered in the chat. Will the national neonatal intensive care nursing be a qualification in itself, or is it part of the critical care nursing? This was answered with yes. Is there a follow-up question on this? Do you want to answer on this a bit more in detail? If no, is there any other question?
Yes, I have a question.
There's another question.
Hello?
Please. Yes.
Yeah, I have a question for Chris, Joy, and Priska. This is Eunice from Zambia, Country Director for 30 Zambia. I just want to check, I'm really interested in the perception and fear among healthcare workers. Just want to check whether this perception and fear is at different levels, for example, for newly qualified nurses or for students, and what mechanisms are there in place to try to address this fear and perception. And this question is on the backdrop of some of the evaluation work we did in Muchinga province, where we found that some nurses actually do not actually come to work for fear of catching COVID. So I just want to hear more, a little bit more, whether it's at different levels depending on experience, and also if there are any mechanisms that you have put in place to respond to this or to address this challenge.
Yes, we have, I'm speaking for the students, because I deal with students more. When the pandemic broke out that time, and first we saw that the private schools, colleges closed, and the government institutions were left as backup for the care in the hospital. And our students, actually, they were so afraid, including the teachers themselves. And the students would do, like, have meetings and come to my office, and they write letters asking to go home. They didn't want to be in school, actually. And even telling them to go to the clinical area again, it was a big issue. So at that time, that very time, we had to, like, make groups. So each group, I think, would maybe have like 2 days in the clinical area, because students were so afraid. And then even also the issue of PPE, also it was so bad at that time. We didn't have enough PPE. So, and then when they go to the clinical area, they would find that the nurses probably, they would have the appropriate PPE and the students wouldn't. And that also even added to their fear. I remember one day, it's like one of the students said they had met someone, had been with somebody who had come from France, a relative. And the whole bunch of the students on the ward went to have to be tested. And then there they were chased. They were saying, no, we don't qualify for that. Then they all came to the school and wanting to go home. And so we had for quite some time lobby with the Ministry of Health to let the students go. So they let the lower years to go, and we remained with the third years. And even then with the third years, because they thought the third years were about to write exams, and probably they could also be helping out in the clinical area. But even then, the situation didn't even help. And they continued pestering until they were left to go home. They were so scared. And even like just the hands-on students, because of, again, the PPE, and also not knowing the people they were dealing with on the wards. And some students have actually acquired the COVID, though none of them had serious symptoms. So even that also added up to the fear. So teachers were afraid, students were afraid, even the nurses in the clinical area, actually. Everybody's afraid anyway. Mm-hmm.
I think just one of the points, some of the points that we've picked up nationally from like stakeholder meetings with some of our partner organisations that we work with here with our colleagues at the South College of Nursing. A big theme has been around stigma, about staff, registered staff that go home that have been nursing COVID patients or potentially COVID patients, and then families shunning them. So, so there is. So I think there's some work to do around stigma, but that comes down to things like information and public health awareness, and sort of trying to, give the right messages, to the community, but also to the healthcare staff. And another theme that's come out, the final theme that I picked up on, was really around recognition. And what's been quite clear is about the nursing workforce is about getting them recognised, and that's not necessarily always financially remuneration, but actually just the thank you for what they've done. And I think that's another theme that has come out that has added to some of the fears and some of the other challenges that they faced.
But then also, like in trying to mitigate that, we have had, initially when the COVID broke out, the pandemic, all the students who were in training at that time were trained in COVID. And then also through the partnership, when we developed the student-specific material, COVID materials, and these materials were how to relate in the classroom setting, in the school setting, in the clinical setting, and also if they go to the cafeteria for their meals, and how to relate in the hostels and so on. So all that material has been developed and students have been trained. But even with that, we see that the fear is still there. And also those that have like tested, we reserved part of the hostel where we could do like keep them instead of sending them home. Those that wish to go home, they go home, but those that wish to stay in school, there's a separate place for them to stay. So that also you see, and when friends hear that a fellow friend has developed COVID, that's also an issue. So the stigma is there, yes, but we're trying to mitigate it.
Okay, thank you very much.
Hello?
Hello.
Yes, I'm Mr. Chair Wisdom from Ministry of Health, Zambia. Just wanted to have a contribution, especially to the last presentation, where I'm seeing emphasis on the type of strengthening of partnerships in terms of communication, a platform of technology. Yes, indeed, it is a plus, especially the way it is with the partnerships which are there, where mostly our partners are in the UK, we are in Zambia, and the type of knowledge we are getting virtually, quite all right. It's well supportive that we are able to apply. But in country, when it comes to certain capacity building programs, it's very, very difficult to hold them virtually due to the issues of likely internet, and there are some courses which are very comprehensive. I'm trying to relate to the program we held previously, and so far, 175 have been trained, but under the QI project we set, where 50, including the 20 undergoing a project, were trained in ICU-based management of COVID-19. With a survey which was done even before, should I say, among us, most providers, critical care nurses, and ASA providers, mostly the non-physicians in Zambia, there was that fear. Even myself, a fear of just catching COVID-19. And the stigma, quite right, is the initial of, for us who are both in office and in the clinical area. Even as I'm talking at home, they are saying you can't be coming either from theater, you pass through theaters, you're going to infect us. Every time there's a roundup, there is suspicion of saying maybe you have COVID-19 or so. Before the training, there was that huge fear where anesthetists could complain with no knowledge, especially of how to manage a patient. And they are the very frontline health workers who are involved in installation of oxygen. No PPEs. It was really a challenge that managing cases when there was the initial breakout became very huge. And even as I'm talking, most of those who are not trained, we are still seeing pockets of them, some records of being infected. But from those who have been trained, most of them, we haven't had any record of them being infected. But even when we are conducting these trainings, we bring them together from different parts of the institution. We are targeting hospitals which are in the borders of Zambia and the huge and bigger hospitals where the COVID-19 facilities. Those who have been trained, they are refusing to attend to the patients, ideally. And we are seeing mostly critical care nurses haven't been trained, most of them, in terms of managing. Because the selection method, especially at hospital level, we find that they are more impartial. Instead of targeting the owners who are more in that in terms of managing patients, it goes to someone who is in the office in terms of trying to be part of the program. Because especially when it is involving per diem, it's becoming a very difficult issue of involvement. So even when we come together to train them, we haven't had any record of contact and infection amongst the trainers because of following the guidelines and protocols. But the fear among those who are trained is no more. So technology, yes, between maybe UK and Zambia, that one would apply, but in country, it's very, very difficult to conduct some of the exercises or training. Because online is somewhere where someone has to be either at home, where there's disturbance, or at work, where you have to be involved in something else and you're dislodged from a program to be conducted. Imagine I could attend this conference just by being at home, not at work, because they won't hear me that I'm attending an important conference, that you have to be given this and that to attend to. So
thank you for this contribution. Sorry, the session is almost at the end, and I would like to raise the last two questions for our representatives from Madagascar, because they are in the chat there. But thank you for your very important contribution. So I would like to ask Caroline, do you have any suggestions of ways to develop trust and collaboration with partners?
Yeah, so it's a very interesting question. Thank you, because it's a quite abstract concept, but I think in the public health world, it's starting to be a very important aspect, the trust among partners. And as you were saying, not only among Swiss and Madagascar, for example, but among teams in Madagascar, the capital team and the rural team. But I think it's using also other ways of interactions and communication, not only strictly related to the project, or not only related, for example, in our situation to the training itself, but to put partners in confidence, like in a safety environment. And from them, we had the suggestion, for example, to create a group team of interaction with using Messenger, for example, or using WhatsApp, which means that people can directly communicate and, for example, ask questions, and there is not like the stupid question, or there's not the way to put like barriers where those are trainers, the other are trainees. So I think this is one way to do that, and to strict at the level of health partners, like health workers with health workers, and not to mix too much also the different actors and the different rules, in order to put everyone in a safety and comfortable like position, having always the support like from us. But as you were saying, it's not easy to do to use technologies at local levels because of obvious problems. But I think it's something that can be improved and that can be used to build this trust relation. But of course, it's not easy, and it's more easy to explain than to put in practice.
Okay, thank you. And the last question for Gracia. Are you able to link your data to other health data, like maternal mortality?
Yeah, so technically we are able to track things like maternal mortality or cases of neonatal death. However, we're only able to track that of those that actually come to the hospitals or to the institutions. So if we see that there are less facility-based deliveries, of course, it's kind of hard to directly draw or even track if those that do not come directly lead to more complications or even death. So yeah, but it's definitely an interesting question, and the literature suggests that that could be one of the consequences of less facility-based deliveries.
Okay, thank you very much. And maybe it could be interesting also for Caroline and Gracia to get in contact and discuss the projects further. And I would like to close this session. Samuel Knaus will report in the plenary on the session later, so I hope you will all join us there and enjoy the rest of the conference. Goodbye.
Bye, thank you.